The muscle energy technique for the piriformis muscle. The patient lies on their back here, turned toward me, so that I do not have to stand and lean over the treatment table while I perform the procedure. The patient should have the leg that is farthest away from me properly treated. So there is a problem indeed with the right piriformis. The patient gently bends the knee up to 90 degrees. It is very important that it is not over 90 degrees at all times. Thus, the piriformis takes on a completely different function in this context. So, 90 degrees at the knee here and at the hip down there in this region. Thus, I place my axilla on the other side of his knee, this way around, and I palpate steadily down near the musculus piriformis. If one is not accustomed to palpating, what exactly should one say? The piriformis here in this lying down position, there is a rule you can feel the greater trochanter, and the distance from the greater trochanter down to the pelvic brim. I rotate 45 degrees downward from here along this direction. In other words, I rotate that same distance downward by 45 degrees, and then I touch the piriformis. There is, in fact, a small opening between the glutes and the gluteus maximus and gluteus medius, where one can slip in underneath here, with a little room to maneuver. From there I take hold with a forked grip under his foot, like this, as shown here. I palpate the piriformis, the knee and hip are at approximately 90 degrees. Then I perform the maximum inward rotation, the maximum medial rotation, that is, internal rotation, by guiding his foot outward, gradually. Then he rotates his hip inward, and when he can no longer rotate any farther into the hip joint socket, I go into abduction, until I can feel with my finger right here near the piriformis that it kind of begins to tighten up. Or this is also called that it triggers, it kind of gives, pulls with. When I have that position, I ask him to perform the 3 movements that the piriformis performs. One function is that it extends. This is achieved by either him pressing his knee up into my own armpit, and it should just be gentle, or that he can stretch his foot. If people are poor at motor control, the patients, it's not a good idea to stretch the foot because you often end up going along as the therapist since you can't keep the patient under control. It is of utmost importance that one maintain a secure hold on the patient completely. He extends his foot here, and then he moves his knee away from me gently. That is to say, he performs hip abduction properly indeed. You move the knee away now, please, carefully. Yes, and the final function is that he should externally rotate the hip, which in turn causes his foot to move inward toward my hand in that direction. That is, he places his foot carefully into my hand in this direction. Do that. And each muscular tension is held very firmly for a minimum of 7 full seconds. In actual practice, when I perform it, I hold it 3 separate times, which amounts to 10 whole seconds for each repetition. Right here, right now, and then he takes a deep, deliberate breath, and as you slowly exhale and completely relax, I rotate inward as far as I can and go a little further into abduction until I can clearly feel the muscle tighten down there. And so I go ahead and do it again, one more time, indeed, extension with the knee raised up into my armpit in that position. He seems to be pressing as if he were trying to push me forward or downward, and then you move your knee away from me after that, very slowly, abduction. And afterwards, you carefully slide your foot very slowly into my waiting hand. Here, of course, there's a short interval, simply to illustrate the 3 movements that follow. Now, take a deep breath in and exhale and relax completely. Internal rotation and adduction, and then I perform the technique 3 to 5 times in sequence.